Well, it's a tough act to follow with Ryan there. I'm Barry Greer. I'm one of the staff radiologists here at Wilford Hall, and today I'll be talking about musculoskeletal ultrasound of the thumb. My objectives today are to be able to identify normal anatomy with ultrasound and to recognize common as well as not so common pathology. I'll cover anatomy first. These are the areas I'll be covering. Osseous anatomy is very familiar to all of us. The first metacarpal, the proximal phalanx, distal phalanx, the first carpometacarpal joint, the metacarpal phalangeal joint, interphalangeal joint of the thumb. To start off the soft tissue evaluation with ultrasound, I'll begin with the ulnar collateral ligament. Ulnar collateral ligament forms a uniform hypoechoic band which traverses the metacarpal, metacarpal phalangeal joint. Superficial to this is the adductor aponeurosis, which is a thin hyperechoic roof over the ulnar collateral ligament. The adductor aponeurosis is depicted in red, with the ulnar collateral ligament depicted in yellow. The radial collateral ligament normal anatomy is essentially the same as the ulnar collateral ligament anatomy minus the adductor aponeurosis. There are two extensor tendons of the thumb, the extensor Pollicis brevis and the extensor Pollicis longus. Distally, these become confluent to form the extensor expansion, which attaches to the distal phalanx. These are shown in a longitudinal ultrasound image delineated by the arrows. Remember that the extensor Pollicis longus starts out medial to Lister's tubercle and then crosses over distal to Lister's tubercle. This is some cross-sectional imaging of the extensor Pollicis brevis and extensor Pollicis longus with MRI and ultrasound images. This is performed at the first metacarpal head. The flexor Pollicis longus is probably the most robust tendon of the thumb. Here we see normal FPL delineated by the arrows with the expected uniform appearance and fibrillar echogenic appearance. And a corresponding MRI image. This is a transverse image of the FPL in both with both ultrasound and MRI. Remember that the flexor Pollicis longus courses between the two sesamoid bones. There are two annular pulleys of the thumb, the A1 pulley at the metacarpal phalangeal joint, and the A2 pulley at the interphalangeal joint. These form thin hypoechoic bands that overlie the flexor Pollicis longus. These can be seen particularly well with dynamic imaging. If you have the patient flex the distal phalanx against resistance, you'll see the pulleys become taut. There's also an oblique pulley over the proximal phalanx, but I don't have any images of that. The volar plate is a fibrocartilaginous structure which reinforces the the volar aspect of the joint capsule and helps prevent hyperextension. This on ultrasound is a triangular echogenic structure which spans the volar aspect of the metacarpal phalangeal joint and the interphalangeal joint. This is delineated in yellow. The muscles of the thumb form the thenar eminence. The most superficial muscle is the abductor Pollicis brevis. Subjacent to this is the opponens pollicis, followed by the abductor Pollicis, the flexor Pollicis brevis, and then the adductor Pollicis, remember, has the aponeurosis which goes over the ulnar collateral ligament. And then the most dorsal muscle, which is not shaded, is the first dorsal interosseous. Ultrasound is an excellent tool for evaluating common pathology of the thumb, to include ulnar collateral ligament tears with and without Stener lesions, radial collateral ligament tears, DeQuervain's Tenosynovitis, Ganglion Cyst, giant cell tumors of the tendon sheath, flexor Pollicis longus tears, foreign bodies, and volar plate injuries. For imaging technique, you'll want to utilize a high-frequency linear transducer. Here we typically use a 17.5 megahertz linear or 15.7 megahertz hockey stick. You want to place the patient's hand flat on table. It may help to have them grasp a rolled up towel, as in this image. Place the transducer in the long axis to the first metacarpal phalangeal joint. Use a liberal amount of gel to maintain contact. Excuse me. And then you'll want to oblique the transducer to maximize the view of the ligament as well as the adductor aponeurosis, and then turn the transducer 90 degrees to get your transverse images, and the radial-collateral ligament can be imaged in much the same way. Ulnar collateral ligament tear is also known as gamekeeper's thumb, as initially described in Scottish gamekeepers when they had snapped the neck of a rabbit between their thumb and forefinger. It is also known as skier's thumb, and is also a common injury in cyclists. Excuse me. It's caused by a combination of hyperabduction and hyperextension, and can result in loss of pinch and graft strength and eventual osteoarthritis. Here's a plain film of ulnar collateral ligament tear with a avulsion injury. Sonographically, ulnar collateral ligament tear depicts the proximal portion of the ulnar collateral ligament retracted and thickened with a hypoechoic cleft between the proximal portion of the ligament and the stump of the ligament that's still attached to the proximal phalanx. The adductor aponeurosis is intact on this example, and again there's the little fragment of the ligament at the base of the proximal phalanx. A Stener lesion is a complete tear of the ulnar collateral ligament with proximal retraction of the ligament superficial to the adductor aponeurosis. The adductor aponeurosis will, since it's interposed between the ligament and the base of the proximal phalanx, prevents healing by conservative means, so surgery is necessary to prevent chronic instability and early osteoarthritis. These are MRI images of a Stener lesion. So you notice that the ulnar collateral ligament is oriented 90 degrees to the first metacarpal head, and then we see the thin adductor aponeurosis coming down, giving that ball and string appearance. Let's see if I can point that out a little better. This is adductor aponeurosis right here. And then this is just the magged up view. And if we turn this view to the orientation that you would see with ultrasound, you'd be imaging the long axis of the finger with the transducer. And you see the ulnar collateral ligament 90 degrees to the metacarpal head, the proximally retracted and balled up above the adductor aponeurosis, depicted here in green. So there's the ball and string appearance or yo-yo appearance. This is a sonographic evaluation of a patient with a Stener lesion. Again, a transducer in the long axis of the finger. We see the ulnar collateral ligament torn, proximally retracted, superficial to the adductor aponeurosis. And on the corresponding image, we see the contralateral thumb, which is normal. This is just another example of an ulnar collateral ligament tear with a Stener lesion. The arrows depict the adductor aponeurosis, and then the ulnar collateral ligament is proximally retracted excuse me, and superficial to the adductor aponeurosis. Radial collateral ligament tears are less common than ulnar collateral ligament tears. You utilize the same scan technique, and these can have a similar you can have a similar lesion to a Stener's with a radial collateral ligament tear if the tear is distal and there's interposition of the abductor of the lateral band of the abductor Pollicis brevis. And, so here we have the proximal portion of the radial collateral ligament thickened and proximally retracted with a hypoechoic cleft, and then you see a little stump of the ligament at the base of the proximal phalanx. DeQuervain's Tenosynovitis is also known as washerwoman's sprain or stenosine tenosynovitis. This affects the abductor Pollicis, Longus, and extensor Pollicis brevis tendons in the first dorsal compartment. This is a repetitive motion injury from grasping and pinching. This is the most common stenosine tenosynovitis in athletes particularly those involved in racket sports, golf, fly fishing, etc. There's pain, tenderness, and swelling over the radial styloid and a positive Finkelstein's test. So here's a sonographic example of DeQuervain's Tenosynovitis. You see fluid around the abductor pollicis longus tendon. The tendon is thickened. There's some loss of the nice echogenic fibrillar pattern, and the margins of the tendon become a little fuzzy and ill-defined. Ganglion cyst is the most common mass of the hand and wrist, as a well circumscribed, like all cysts on ultrasound evaluation, it is well circumscribed, anechoic, imperceptible walls, good through transmission, and no internal flow. Sometimes you'll see these become a little complex if they've been infected previously or if there's been bleeding into the cyst. Giant cell tumor of the tendon sheath, Ryan touched on this. This is a form of pigmented villonodular synovitis, which is a benign hypertrophic synovial process that can be villous nodular or villonodular with varying degrees of hemosiderin deposition. The PVNS can be diffuse or focal, can be intra or extraarticular. Extraarticular forms include those that affect the bursa and the tendon sheath. Giant cell tumor of the tendon sheath is the second most common tumor of the hand, wrist, ankle, and foot, just next to the ganglion cyst. These are hypervascular, and giant cell tumor of the tendon sheath is the most common form of PVNS by a factor of 3 to 1, and it has an occurrence of 9.8 per million population with a slight female predominance. It's typically found in the 3rd through 5th decade of life. Most commonly presents as a soft tissue mass of the hand or wrist, and next would be the foot and ankle. Ultrasound will show a well circumscribed hypoechoic mass intimately associated with the tendon. Can have small extensions of the mass around the margins of the tendon, or it can completely encase the tendon. On dynamic imaging, this does not move with the tendon because this is a synovial process. So ultrasound is excellent in this regard. It's highly vascular, and you'll see increased flow on Doppler imaging. Plain film will be normal in about 21% of the cases. 50% will show extrinsic erosions. But for to be diagnostic, you have to get an MRI, which shows the dark foci of, from hemosiderin deposition on T2-weighted imaging and blooming on gradient echo. So here's an example taken from AJR, August 2004, of giant cell tumor tendon sheath, and this looks very similar to the one Ryan had, so maybe the same issue. But the axial image with the color Doppler shows the increased vascularity. In this case, it completely encases the tendon. It's hypoechoic. Flexor pollicis longus tears can also be evaluated with ultrasound. These are some short axis images that demonstrate the intact tendon distally. However, it is thickened and there is fluid around the tendon. Then we start to see some intrasubstance tearing with fluid around the tendon and tendon sheath. And then we see absence of the tendon. And then here's long axis imaging. Distally, the tendon has a more normal appearance, but as you come proximal, the tendon becomes thickened. The margins become irregular. You start to see intrasubstance tearing, and then there's a gap in the tendon, followed by the proximal tendon stump. Ultrasound really shines in the evaluation for foreign bodies. Radiographs only detect about 15% of wood splinters. 5 millimeter foreign body detection sensitivity by ultrasound ranges from 89 to 94%, with a specificity of 93 to 99%, and is only slightly less for 2.5 millimeter foreign bodies. Nearly all foreign bodies, to include glass, plastic, metal, and wood, are echogenic with varying amounts of shadowing. If the foreign body has a flat surface and this is perpendicular to the beam, you can get reverb artifact. And another thing that will help in the evaluation is this thin hypoechoic band around the foreign body, in this case a splinter, which represents inflamed tissue. Ultrasound is also excellent for detection of soft tissue complications such as abscess, tenosynovitis, or pyotenosynovitis, etc. Volar plate avulsion injuries can also be evaluated with ultrasound. In this case, excuse me, we have a plain film of a ring finger with a volar plate avulsion fracture at the proximal interphalangeal joint. These are common sports injuries with jammed fingers caused by hyperextension, posterior displacement of distal phalanx. So this same patient came to us for ultrasound examination because they could not flex their distal phalanx, or at the distal interphalangeal joint. So at the PIP, you see the disruption of the cortex and the volar plate fracture. But what we were surprised to see is at the distal interphalangeal joint, a similar finding with disruption of the cortex and a volar plate avulsion injury, which we could not see on the plain film. So in summary, thumb sonography is low cost, it's fast, it's easy to perform, don't have to worry about radiation, can perform dynamic imaging during the scan. It provides accurate diagnosis of tendon and ligament injuries. It's useful to differentiate cyst versus solid, and is the study of choice for foreign bodies. Are there any questions?